Serio from the Medical Genetics, University of Siena in Italy. And the title is Liquid Biopsy, a New Strategy to Face Different Advanced Solid Cancer. So please, you can start your talk.
Thank you. Good morning, everyone. As said, I am Serio Bianca, and I am a PhD student in medical genetics at the University of Siena. And it's a pleasure to be here and to share with you our data from the recent research of our lab. So, okay. Just one slide to explain the complexity of the scenario. Actually, cancer is an evolving microcosm driven by selective pressures due to the environment and drug therapy. And daily experience shows us that there are two major groups of tumors, the oncogene addicted and the non-oncogene addicted. The first group can be controlled for many years before tumor relapse using standard protocols, hitting their molecular targets. But they are very few. The majority are non-oncogene addicted, so it becomes very important their genetic characterization and the detection of the different somatic gene mutations that can be involved in the tumor progression. Furthermore, we have to consider that for the treatment choice, it's very important to distinguish between germline and somatic mutations. To do all these things, we can use liquid biopsy that analyze the cell-free DNA and that let us to be able to identify the somatic tumor mutations in a non-invasive manner, obtaining the information of the primary tumor and of metastasis in a single experiment. The benefits of liquid biopsy against the standard one are many. It is quicker, it is easily to obtain, it is minimally invasive, and it can be repeated over time. We enrolled 225 patients with 25 different solid tumors at the medical genetics unit of the Azienda Ospedaliera Universitaria Senese. And these patients experienced disease progression after standard therapy. The median age was 59. In fact, we had 52% of male and 48% of female, and the sexes were balanced. The patients were excluded if they had an early stage solid tumors, while the inclusion criteria provided patients with locally advanced or metastatic solid tumors independent from the primary tumor site. From all, we took a peripheral blood draw in strep tubes, and we separated from it the plasma, obtaining around 4 ml of it. We extracted cell-free DNA and built libraries using a Vinio circulating tumor DNA expanded kit. That is a kit that provides a genes panel of 77 genes associated to cancers. The sequencing was performed on Illumina NextSeq 550, and we were able to observe different types of alterations, like single nucleotide variations, insertion, deletions, gene fusions, copy number variants present in genes linked to cancer. The sequencing analysis was performed using a Vinio oncology analysis software. So, as said before, our court presented 25 types of different solid tumors, and at your right, you can see the distribution of the patients for type of cancer. Of the 225 patients, 68% resulted positive to the first liquid biopsy, and we found a total of 227 pathogenic variants in 54 genes. The cancers with the greater number of mutated genes were breast, lung, colorectal, pancreatic, and prostatic cancer. We observed that the genes more frequently mutated were regarding cyclonucleotide variations, TP53, KRAS, PIK3CA, PTN, and BRCA2. And in particular, TP53 resulted resulted mutated in 42% of cases. Regarding the copy number variations, the genes more frequently mutated were EGFR, MET, ERBB2, and FGFR3 with these percentages. The mutations on TP53 were the 20% of the entire pathogenic variants found. So intrigued by this data, we observed if there were present other mutations in the other genes more frequently mutated. And effectively, we saw that the TP53 resulted mutated in association with the PIK3CA and KRAS in 18% of cases, with EGFR in 16, with MET in 12, and with FGFR3 in 6% of cases. Here you can see at the bottom of the slide the different types of tumors in different colors, and we can observe that the genes more frequently mutated. And effectively, TP53 was present in all the types of cancers, respect the others. From 144 patients resulted positive to the first liquid biopsy, we were able to do the second one on 42 of them, and 31 resulted again positive, while 11 were negativized. We found mutations in 31 genes, and 58% of these patients showed again the permanence of the TP53 somatic mutations. Here I have reported the 31 genes, and as you can see, the breast, the lung, and the prostatic cancers remained the cancers with a major number of mutated genes, while TP53, PIK3CA, KRAS, and EGFR resulted the genes more present in different types of mutated genes in different types of cancer. So we asked ourselves how many somatic clones were driving the tumoral progression, and we observed that in the majority of cases they were 1 or 2, confirming our previously data found. So we did a comparison of the results obtained from the first liquid biopsy with the second one, and we saw 3 different situations. The first one was that one we observed that the variant allelic frequency of the mutations found didn't change from the first liquid biopsy to the second one. For example, in this case of breast cancer, we found a mutation on TP53 with an IF around 22%. And in the second liquid biopsy, we found the same variant with an IF of 21.56%. So it remained constant. Another situation was that one we observed the increase of AF from the first liquid biopsy to the second. And in this case of a pancreatic cancer, we found in the first liquid biopsy 2 mutations, one on TP53 and the second one on KRAS with an AF of 6.60%. In the second liquid biopsy, we didn't find the variant on TP53, but we observed that the variant on KRAS increased to 0.38%. The last situations that we observed is the increase of AF from the first liquid biopsy to the second one. And in this case of breast cancer, we found a variant on PIK3CA with an IF slightly more of 7%. And in the second liquid biopsy, it increased to around 50%. Another example is the this ovarian cancer, where we found a TP53 mutation with an AF of 28.57%. And the second liquid biopsy, we found the same variant with an AF increased to 33.41, but we found a couple number of variants in FGFR3 too. After I've done the comparison of the results from the first liquid biopsy to the second one, we observed this data. In the graph A, you can see that patients with 2 mutated clones were more in a relapse stage respect that ones had 1 mutated clone. And the same considerations from the increase or decrease of AF in the patients. And we observed in graph B that patients who presented an increased AF in the second liquid biopsy of the same mutations were more in a relapse stage respect that ones who present a decreased AF that who were in a regression stationary stage more frequently. So from a cohort of 225 patients with 25 different solid tumors, 144 resulted positive to the first liquid biopsy on 54 genes with a total of 227 pathogenic variants found. Of them, 31 resulted positive to the second liquid biopsy with mutations on 31 genes and the majority with 1 or 2 driver clones. From both from the first and the second liquid biopsy, TP53 resulted with gene more frequently mutated. So in conclusion, liquid biopsy is a very useful technique in the detection of somatic mutations that enables us to follow up the behavior of the different types of cancer. More cooperation and sharing of information between the different specialized figures maybe bring us to better understand the mechanism of growth, permanence, and resistance of the cancer and find the right therapy for each patient using a personalized treatment. I thank you for your attention, and I would like to thank in particular with Professor Alessandra Ranieri, Professor Elisa Frullanti, and Dr. Maria Palmieri, but also to all my colleagues of the Lab of Medical Genetics here at the University of Siena. Thank you for your attention.
Thank you for your presentation. So I guess it's very interesting. And is provided in different, I mean, a new vision of the identification of mutation in cancer patients. I don't see a question in the chat, but I would like to start with a sort of comment. Do you think, or you are planning to, in case in the patients they develop a metastatic tumor, to correlate the mutational profile liquid biopsy for the one, I mean, if the tissue biopsy will be available with the one with the tissue to see if there is any correlation between the two aspects, the two profiles?
Yes, if the tissue biopsies will be accessible, so we can take it. It's a thing that it can be very, very useful for us for understand what if liquid biopsy can be used like the tissues one, if right. It is informative like done the tissue one, and to see if the tissue or from plasma we find the same variants. So it can be a way to validate the mutations too.
Exactly. Yeah, yes, it's very, and actually, I mean, I have another comment on that because, I mean, not only, as you mentioned, that will be a very important tool for, I mean, for a prognostic also role to assess the prognosis of the tumor in patients, but also for a therapeutic point of view, because, I mean, you might be aware that now there are Also, immunotherapy is targeting neoantigens, so mutation in patients. So this might be also an interesting tool to evaluate for this type of approach.
Yes, for that genes that are targetable, it is very useful because we can think to the personalized therapy for each patient. And actually, following the EF from the different biopsy, from the first, the second, and so on, we can observe the regression or the progression of the tumor. So we can regulate, we can change the therapy looking the results of the liquid biopsy, because we have an idea of the frequency, the mutations, or the frequency of the mutations of clone. So we can understand if in some cases there is resistance to the treatment, for example, because some genes can be mutated after the first therapy, the first treatment. They can envelop the resistance after.
Okay, we have also here a question in the chat. So, inclusive criteria for your patient were for advanced cancer. Do you suppose you will not obtain circulating DNA in early stage of cancer?
It is we haven't supposed it, but it can be useful to do some prediction evaluations. So yes, thank you for your suggestion.
Okay, so thanks a lot for your talk and presentation. So we can move to next speaker. So next speaker is Elena Lastraioli. Okay, can you start to share your presentation?
Yes, of course.
Okay, so meanwhile, so I will introduce the speaker. So Elena Lastraioli. From the Department of Experimental and Clinical Medicine from the University of Florence in Italy. And the title of the talk is RAS Mutational Status Evaluation in Liquid Biopsy to Monitor Disease Progression of Metastatic Colorectal Cancer Patients. So please, you can start your talk.
Thank you. Thank you for the organizers to invite me and to give me the opportunity of presenting our data. I think I will might add some pieces to the previous talk, so it comes good that I follow the presentation of Viola. So as she said, liquid biopsy is an alternative to tissue biopsy. It has some advantages as well as some disadvantages, let's say. First of all, it is less invasive than tissue biopsy, but it can't be used for histological diagnosis for obvious reasons. But maybe some of the main characteristics that make liquid biopsy extremely valuable for cancer management is that it can take into account tumor heterogeneity, while in tissue biopsy it is often impossible to detect tumor heterogeneity. And it can be used for disease monitoring. That is what you were saying with your questions. So while solid biopsy, tissue biopsy gives us just a single snapshot over time and space, liquid biopsy can be used to have a more complex and more precise, maybe, picture. But actually the gold standard for diagnosis as well as for management in terms of therapy for solid tumors still is tissue biopsy. So this is an important thing what Viola was saying. So to try to understand whether liquid biopsy could somehow be added to tissue biopsy, or could also overcome the problems raised by tissue biopsy. So our question was, are there concordances between the two evaluations? And if it is so, can liquid biopsy be used instead of tissue biopsy, or must the two evaluations be performed simultaneously? So as Viola said, ctDNA is found in blood. It is released from necrotic and apoptosis tumor cells directly into the bloodstream. And it has a quite low concentration in the blood. What was the object of the last questions that Viola received is that, yes, it's true, it will be quite important to detect it also in early stages, because some tumors, for example, I'm thinking about pancreatic cancer, would surely benefit from another tool to early diagnose the disease. But what was demonstrated some years ago was that, reported here in this graph, that is in advanced tumors, and here are reported colorectal, gastroesophageal, pancreas, and breast. The frequency of circulating tumor DNA is higher in advanced disease with respect to locally advanced. So that's why in general, we use this approach for metastatic patients with respect to the others. And moreover, because generally these patients are, of course, patients with serious health problems. So we must try to avoid multiple tissue biopsy in these patients. And as I will show you in a while, in this cohort of patients could be quite useful to monitor the therapy in order to change the schedule according to the presence or absence of particular mutations. An example of that is represented by RAS mutation status. In colorectal cancer, it is well known that if the tumor is harboring RAS mutation, it can be used a standard chemotherapy or chemotherapy combined with target therapy. But what was shown long ago is that if there are RAS mutations, it's not useful to give the patient an anti-EGFR therapy, because in this condition, if RAS is mutated, it is constitutively activated. Therefore, it does not depend on EGFR signaling. So we can block EGFR, but we have no response because the lower part of the signaling cascade involving RAS is already functioning. While on the contrary, in patients that don't harbor RAS mutation, so that are RAS wild type, we can use anti-EGFR therapy, and it is a good kind of therapy, and frequently it gives good responses. To monitor the emerging of RAS mutations over the time, we can think of using sequential blood samples at different times in order to understand whether a mutation is coming up or not. And this can help us deciding to change the schedule according to RAS mutational status. This was the starting point of our study. So we decided to use a difference from what Viola reported. We did not choose an NGS, but we use another technique, that is beaming. Beaming is a quite useful technique in terms of high sensitivity. And the core of the technique is represented by an emulsion PCR. So we can extract DNA from plasma, then amplify it and link it to magnetic beads. And then with emulsion PCR, we have single droplets with one containing just a single DNA copy. So following that cycles of amplification in emulsion, we can perform an hybridization using fluorescent probes, and the final detection is performed through a flow cytometer that is dedicated to this technique. We use this kit OncoBeam RAS CRCSA, and that is designed for stage 4 colorectal cancer patients, and it allows us to evaluate K and N RAS mutation in specific codons that are reported here. So exon 2, 3 for A, for B for KRAS, and exons 2, 3, and 4 for NRAS. And the end result of the test is the mutational status of K and NRAS in plasma, so in circulating tumor DNA. This is the result of the test gives us a precise information that is RAS is mutated or not, but it also gives us other information about the mutant allele fraction, as we will see in a while. The test has been validated, but it's not included in standard clinical practice yet. So at least here in Italy, the gold standard is still tissue biopsy and molecular analysis on it. Moving to our experience in particular, we first published this paper last year, and we showed here that there is a concordance between KRAS and RAS mutational status detected on plasma and the one detected on tissue. So we, just for RAS, but we can somehow answer to the question that was made to that was asked to Viola. So yes, we have a good concordance between tissue and plasma analysis, but as we said before, our impression was also starting from this paper that both tissue and plasma analysis should be performed at least at the beginning, at the diagnosis. Starting from this cohort of patients, we then focused our attention on a case report, that is this one I report here. In these patients, we noticed a quite interesting profile. That is, these patients have a quite long clinical history that is reported here in this picture. So it was first diagnosed in 2005. Then in 2014, it was diagnosed for metastatic disease, and it was tested for RAS on tissue biopsy, of course, and it turned out to be RAS wild type. Therefore, the clinicians decided to, according to their guidelines, to treat him with an anti-EGFR, that is cetuximab, and he had a complete response, followed by partial response and disease progression in a quite long time, because he was treated with cetuximab for 2 years. That for a metastatic patient is a quite long period of time. Then, since he stopped and responding the therapy with cetuximab. The therapy was changed to bevacizumab. Then he also, in this case, he went on progression. So he was treated with other oral drugs than FOLFIRI, and with FOLFIRI he had a partial response, but nevertheless the therapy had to be stopped. It was then treated with degramon and once again with cetuximab for a rechallenge strategy. But also in this case, despite having responding so well to the first administration of cetuximab, in this case, the result was not good. So the patient went on disease progression and finally died. What was changed between 2014 and 2018, in which he did not respond to his challenge, was that in this period, RAS mutation has arisen. We know that because in 2018, we performed our evaluation with beaming, and we found that this patient had not one, but two mutations on RAS. Specifically one on KRAS codon 12 and one in NRAS codon 61. That is a quite weird situation because normally these mutations are mutually exclusive. So it's quite strange to find both a mutation on KRAS and NRAS, but this was the case. So what we would derived from this case report was that in this particular case, if liquid biopsy would be integrated in the clinical practice, maybe this patient would have not been subjected to a challenge strategy, because knowing that he had mutations in both RAS K and NRAS, maybe the cetuximab was not the best choice. But we must also keep in mind that in this particular case, since the clinical history of the patient was so long, he more or less received all the treatment possible. So maybe in this particular case, rechallenge was the last thing to do. But nevertheless, we can underline the fact that if it is possible to perform a liquid biopsy analysis in a patient that did responded well to a therapy and then he stopped and progressed with developing metastasis or so on, we can better identify patients who would benefit from a therapy instead of another. In this case, in particular, of a challenge, but not only. So we, basing on this experience we got, we moved on, and we have now an ongoing project that is the logical sequence of the previous one. It is now we are enrolling patients and they get standard tissue biopsy and liquid biopsy at baseline. Then, basing on tissue biopsy results, they are subjected to different schedules of treatment, and samples are blood samples are taken at 4 weeks, 8 weeks, and every 12 weeks until disease progression. So, in this case, we can not only evaluate the baseline, so the concordance between tissue biopsy and liquid biopsy, but also perform a monitoring during the therapy. In this case, the referring hospitals are those of Pistoia and Pescia, and K and NRAS status are evaluated with NGS. While on plasma samples, we use the same kit as I showed you, so the OncoBeam RAS CRCSA, but also we included the IDILA test, mutation test. IDILA is a completely different approach because it is a technique based on real-time PCR, and it is an automated platform that is quite easy to use, quite cheap, and it gives you results within 2-3 hours, more or less. While beaming, as I showed you, is a complex disease. It's not cheap, it's time consuming, but it has a great sensitivity, while real-time PCR has a lower sensitivity. So what we planned to do was to compare also these two techniques to understand whether it could be used a simpler one instead than a complex and expensive one, that is beaming. Keeping in mind that, of course, IDILA has a lower sensitivity than beaming, but it could be that the sensitivity is enough, let's say, for the clinicians to drive their conclusions. So we decided to test also this aspect. The results we got are reported here. So we confirmed a quite good agreement between NGS and OncoBeam for both KRAS, that is around 90%, as well as for NRAS, that is 100%. While for IDILA, we have a lower concordance agreement between IDILA and NGS, that is around 60%, and it can be explained due to the lower sensitivity of the technique. While we have a quite good agreement, perfect agreement for NRAS. IDILA can also evaluate BRAF mutations that are detected in tissue with NGS, but that are not detected with OncoBeam because the kit is not designed to evaluate also BRAF. It should be used another kit, but it was not the main object of our study. So with evaluating BRAF, we have a good agreement between NGS and IDILA. When we evaluated the concordance between beaming and IDILA, we got a lower percentage of agreement, but it was somehow expected due to the difference in the sensitivity between the techniques. For NRAS, it was as well as before 100%, but we have to keep in mind that the most frequent mutations in colorectal cancer patients are those of KRAS, not of NRAS. NRAS is mutated at a very, very low extent. So it's more frequently found wild type instead of mutated. So it could explain also the perfect agreement we get between the different techniques. I told you before that beaming not only gives us a yes or no response in terms of a mutation or wild type RAS, but it also gives us a quantitative value, that is the mutant allele fraction. So we decided to evaluate whether the values of MAF were maintained or changed at the baseline 4 weeks and 8 weeks in the different patients. So we noticed that it is reported here in this scatter plot. We noticed that there is a variability not so high, but there is a certain degree of variability. Although in the measure percentage of samples, if there is a mutation in RAS, it is maintained over the weeks, as well as the absence of mutation. So wild type samples maintain the same status as well as mutated, but it is not not the rule. Sometimes we have different situations. So we decided to analyze the single patients in their clinical course over therapy, and according to the best response detected from the clinicians. What we got was quite interesting in my opinion, because we noticed that, for example, in patient number 1, at 4, we have a decrease of the MAF at 4 weeks, while a sharp increase appeared at 8 weeks, and it corresponded to a disease progression. For samples, patients 2 and 7, we had a different trend. So we had a decrease once again at 4 weeks of treatment, and a slight increase at 8 weeks. So it could be concordant with the clinical response towards of stable disease. The same stands for the patient number 7, in which the increase was a little higher because it started from 0 value of MAF, but nevertheless, it did not reach the threshold. So the values of MAF are comparable with concordance with the fact that he got a stable disease. Patient number 4 and 5 have a partial response that is highlighted here because this patient had a quite high value of MAF at the beginning, at the baseline, then it decreased until 0, and then it started again increasing, but at quite low extent. And this is this could be explained with a partial disease, that a partial response of the disease that was observed. For patient number 5, it was a similar situation to that of patient 3, but in this case, he had a partial response. So he started from a baseline value quite low. Then he had an increase at 4 weeks and a decrease at 8 weeks that bring him again at the same levels of the baseline. But what we noticed is that patient number 3, that has a complete response, he had a profile that was similar to that of number 5. So an increase at 4 weeks and an increase at 8 weeks. But in this case, he started from 0 and went to 0. So the MAF was completely abrogated. And this could be explained, said, with the complete response he got. But despite observing the response of the patients, we were interested in evaluating the type of therapy, because these patients received different kind of therapy. But in some cases, there were some patients that received the same schedule, that is patients 1 and 2, that has a FOLFIRI and bevacizumab, but had a different response. But we all know that the clinical response is not only based on the drugs administered, but it is depending on a lot of intrinsic factors, so we can't focus only on that. But interestingly, we also have another patient, that is number 5, that had a partial response and that was treated with capox, but bevacizumab as well. So we could try to understand whether the presence of bevacizumab, that is the common feature between these 3 patients, could explain the trend of the values of MAF. The same can be done for between patient 2 and 3 that were treated both with FOLFIRI, but in the case of number 2, FOLFIRI plus bevacizumab, and 3, just FOLFIRI. So what we are planning, actually are doing now, is of course to complete the enrollment, because we plan to enroll a higher number of patients than that I reported here, to analyze all the samples at 0, 4, 8, and 12 weeks, and to draw conclusions about the clinical relevance, especially focusing on the response and the kind of therapy. These I put here as a future perspectives. Actually, we are already performing all these steps, and some of the data are almost done. So we hope to finalize the experiments in the next weeks, or at least next month, and to publish all these data. And I conclude just thanking the people who made it possible for this project to be real, especially the patients and their families that allowed us to collect their samples and clinical data. And then the personnel at the University of Florence Department of Experimental and Clinical Medicine, where I work with Professor Rosa Arcangeli, and the nurses, surgeons, oncologists, and data manager of the hospitals that gave out the samples, that are the Hospital of Pistoia and that of Pescia. And last, of course, I want to thank the Fondazione Cassa di Risparmio di Pistoia e Pescia for their financial support. And I thank you for your attention.
Okay, thank you for your talk. Very interesting, in particular with the perspective of the clinical application, and even making, possible application for prognosis of patients and responses to therapy. I'm wondering if your data, you have in mind, or you did already, any correlation with the microsatellite status of the colorectal cancer patient, because for example, I will expect a microsatellite instability, they will generate more mutation. So you might have more, target genes to monitor in that case, as compared to more patients with the microsatellite stability.
Yes, that's a quite good point. We did not it already, but actually we are planning on doing it, also because the IDELA platform also have kits for detecting MSI. So we are planning on expanding the study also in this direction. Thank you.
Okay, very interesting. And actually, I saw you are focused mainly on the BRAF status of mutation of the patients, but my question is, it would be interesting even to monitor other genes that are in some way actionable, mutations that are actionable with other targets. In addition to that, even to consider the mutation, this data in association with the, to design combinational therapy, because as you saw, some patients reach, for example, a partial response. Only one patient was able to develop, complete responses. So it might be useful even to think about application on your data to identify any possible combinatorial therapy that could be applied besides,
Yes.
I mean, the standard
Yes.
therapy.
Sure, of course, we are actually moving also in this direction to expand the panel of mutations. We started from RAS because of its relevance, of course, and also because we had the possibility of using this kit for OncoBeam that is designed for RAS. But we are now trying to evaluate also other mutations, and we are also planning about moving to other malignancies, in particular lung cancer. So we are still at the beginning, but we try to go further.
Okay, thank you. I don't see any question in the chat, so I would like to thank you for this interesting presentation. Hopefully we will hear back soon with more results and probably for clinical
I really hope so.
So thank you again.
So
let's move to the next speaker. Is from Sonia Castillo Luva from the Universitat Complutense de Madrid, Spain. The title of the talk is the IL-1B secreted by cancer-associated fibroblasts depends on the RAC1 activity.
Hello, can you hear me? I don't know why my camera is not working.
We can hear you and we can see your slides.
Okay, perfect. So good afternoon. Sorry about the problem with the camera. I don't know why it's not working. Okay, so good afternoon. My name is Sonia Castillo from Complutense University in Madrid, Spain. And today I'm going to talk to you about the role of the small GTPase RAC1 in tumor microenvironment. Cancer is the most frequent cancer in women and the major cause of cancer-associated death worldwide. As in other cancers, the origin lies in the uncontrolled division of the tumor cells. However, the mortality for cancer is not coming from this proliferation, but the ability of these tumor cells to invade other tissues in a process known as metastasis. Molecular classification of breast cancers depend on aspects related with the therapeutic decision making. Thus, we have the hormone-positive breast tumor, referred as luminal A or luminal B. Then we have the HER2 positive breast tumors, and finally the triple negative breast tumor that do not express the HER2 receptor or the hormone receptor. The luminal tumors are the ones with better prognosis, and the triple negative breast tumors are the more malignant ones. Most deaths associated with breast cancer are due to metastasis. Moreover, even in the case of luminal tumors that are the less aggressive, these tumors can produce metastasis years or even decades after primary tumor has been removed. Preventing the establishment of metastatic lesions will contribute to convert cancer into chronic rather than fatal disease. Cancer develops in complex tissues environments that sustain the growth, the invasion, and finally the metastasis. Bidirectional communication between cells and the microenvironment is critical for tumor growth. Thus, we need to understand how the tumor microenvironment influences breast cancer development in order to identify new therapeutic strategies to improve the anti-cancer treatment. Tumor consists of tumor cells and the tumor microenvironment. The tumor microenvironment contains both cellular and non-cellular components with different cell types, such as immune cells, endothelial cells, fibroblasts, or non-cellular components such as extracellular matrix or cytokines. Fibroblasts are the most abundant cell type in the tumor stroma and also as known as cancer-associated fibroblasts or CAFs. The small RAC1 GTPase is a molecule that has been implicated in cancer initiation, progression, and malignancies in various tumor types. Indeed, there are considerable evidences that enhancing RAC1 signaling is associated with tumor formation, growth, and metastasis. Actually, RAC1 is an important regulator of the EMT program, epithelial to mesenchymal transition program. This program is activated in solid tumor to induce tumor dissemination, and it has been proposed that inactivation of these GTPase could be used as a therapeutic target in breast cancer, mainly by blocking the tumor dissemination. RAC1 is a member of the Rho family of small GTPases that cycling between an inactive GTP bound state and an active GTP bound state. There are positive regulator called protein and negative regulator called GAPs or ROTTI that control the activation of these GTPase. When RAC1 is bound to GTP, can interact with different effectors, controlling multiple events in the cells such as proliferation, transcription, or migration and invasion. Overexpression of RAC1 together with deregulation of RAC1 regulator has been considered the main perturbation to RAC1 signaling in cancer. However, the influence of the RAC1 activity on CAF signaling to promote tumor development has not yet explored. We started analyzing, doing an in silico study, and we found that RAC1 expression was significantly stronger in invasive ductal carcinoma, in the stomach of invasive ductal carcinoma, compared with normal tissue. We examined paths of different cancer-associated fibroblast from different molecular subtypes obtained from breast cancer patients, from better prognosis, the luminal 1, to worse prognosis, like triple negative subtypes. We analyzed by qPCR the expression of RAC1 in this CAF, and we found that RAC1 was overexpressed in this CAF compared with the normal fibroblast, but we didn't find differences on total RAC in these CAFs. As I mentioned before, RAC1 is a small GTPase that need to be bound to GTP in order to be activated. So we can detect RAC1 activity by a simple pull down assay in which we detect RAC bound to GTP that interact with the cryptomain of PAC1, a non-RAC1 effector. Analyzing the activity of the GTPase, we found that RAC1 activity diminished as tumor became more aggressive. So RAC1 activity in luminal CAF were higher than in the most aggressive CAFs, the triple negative breast cancer. Thus, to evaluate the consequences of inhibiting RAC1 activity in CAF, we use a drug that inhibits RAC1 activity by blocking the action of the KEF protein. As you can see in this Western blot, in these images, the inhibition of RAC1 in luminal CAFs, that's the one that express RAC1, reduce the activation of this, the activity of this GTPase to similar levels observed in triple negative breast cancers CAFs. So what we did was to inhibit the luminal CAFs with this inhibitor, and then we incubate in serum-free to collect conditional medium that was used to treat breast cancer cells. As you can see, conditional medium from CAFs promote proliferation relative to normal fibroblasts, conditional medium. And the conditional medium of CAF treated with this RAC inhibitor strongly enhanced breast cancer proliferation. These results were corroborated by staining with Ki67 proliferative markers and with analyzing the cyclin E1 expression. We assess the effect of conditional medium on tumors and migration and invasion. And you can see CAF conditional medium enhanced the tumor migration as well the tumor invasion more than the normal fibroblast. And the inhibition of RAC1 activity in CAF produces a conditional medium that strongly stimulates tumor migration as well as tumor invasion, similar to the conditional medium obtaining from triple-negative breast cancer CAF. Moreover, when we overexpress RAC1, constituted RAC1 active construct in these triple-negative breast cancers, that are the ones that have low activity of RAC1, we prevent, as you can see here, we prevent the protumorogenic activity of these CAFs. So these results suggest that inhibiting RAC1 activity in luminal CAF cells drives the protumorogenic effect of these CAFs. Confirmed that the observed phenotype was due to RAC1 specificity, we depleted genetically RAC1 by using siRNAs. As you can see here, the siRNA was able to reduce the total RAC as well as the total active RAC. And we cause similar effects. So using this conditional medium, we check for proliferation and the depletion, genetically depletion of RAC1, increase the proliferation as well as the migration and invasion of the breast cancer cells treated with this conditional medium. Since CAF stimulate tumors and migration and invasion through the secretion of different cytokines into the tumor microenvironment, we wonder if RAC1 might suppress the production of cytokine gas. Thus, we use an antibody array that were incubated with conditional medium obtained from CAFs or from CAFs that were inhibited or RAC activity. We got different differences. For instance, we saw a decrease in the secretion of the stromal derived factor 1 or an increase in the secretion of interleukin beta or interleukin A. We confirmed the results by analyzing the secretion levels of interleukin 1 beta and interleukin A by ELISA, and we only were able to confirm the increase in interleukin 1 beta production after RAC1 inhibition, but no of interleukin A. Similar results were obtained when we genetically RAC1 with these siRNA. So we found an increase in the secretion of interleukin 1 beta, but no differences in the secretion of interleukin A. So we know that when we inhibit these CAF, luminal CAFs, we get an increase in the secretion of interleukin 1 beta. So to study whether this increase in interleukin 1 beta secretion may drive the protumorogenic activity observed after RAC1 inhibition, CAFs were treated with a specific pool of siRNA to deplete interleukin beta. Genetically depletion of interleukin beta reduced the expression as well as the secretion of this cytokine into the conditional medium. The conditional medium obtaining reduced the increase in RAC1 activity observed in breast cancer cells, as well the migration and the invasion observed when RAC1 was inhibited. As an alternative approach, we target interleukin 1 beta in the conditional medium using a neutralizing antibody. We confirm by ELISA that antibody neutralized interleukin beta secreted into the medium. And when interleukin 1 beta was inhibited in the conditional medium from RAC1 inhibited class, breast cancer cell migration was no longer observed, presumably because the system failed to stimulate this RAC1 activation in these breast cancer cells. To investigate the relevance of our finding in vivo, we inoculate the CAM membrane of date 11 chicken embryo with breast cancer cell expressing the GFP marker in the presence of calves or calves pretreated with RAC1 inhibitor for 22 hours. So the first thing, this experiment, it takes like 7 days, almost 7 days for the tumor to grow. So we confirm that RAC1 inhibition was stable at least for 3 days. So we inoculate this breast cancer cell line together with calf or RAC or calf that were inhibitor for RAC activity, and then we treated this tumor that were generated with neutralizing antibody at day 4 and day 6 after inoculation. As expected, tumor derived from co-inoculation of RAC1 inhibited calves and breast cancer cells were longer and heavier than controls. Furthermore, the interleukin 1 beta antibody dramatically reduced the size compared with the control that was treated with the antibody control, the IgG control antibody. Moreover, we can analyze in this model the lung metastasis, and as you can see here, because the breast cancer cell that we're using for this experiment to generate tumor, we can observe GFP positive signal coming from these breast cancer cells in the lung. As you can see in these images, the culture of the co-inoculation of breast cancer cell with this calf that were inhibited in RAC activity migrate more to the lungs or have more metastasis. We can analyze as well metastasis by testing the human allo sequence in the chicken lamb by qPCR. And as you can see in this graphic, we observed an increase in relative metastasis when breast cancers were cultured with calf treated with RAC inhibitor, and treating this tumor with the interleukin antibody revert this metastatic phenotype. To confirm the implication of RAC1 in tumor development, we checked whether blocking interleukin beta signaling affected activation of this GTPase. So we analyzed the activity of RAC1 in all these tumors, and what we found is that tumors generating in the presence of CAF inhibited RAC1 induce an activation of this tumor, and this activation was abolished by interleukin 1 beta antibody. Furthermore, aberrant RAC1 tumor activation affects the activation of the important signaling pathway like ERK or AKT. As you can see here, the pretreatment of gas with this inhibitor increased this signaling pathway, but treating this tumor with the anti-interleukin 1 beta antibodies reduced this signaling pathway. In the clinic, both epithelial and stomach compartment are treated with the conventional therapy. Thus, we analyze the consequences of treating the tumors and and have the tumor generating the presence of CAFs and the breast cancer cells at the same time. As you can see here, the treatment of breast cancer cell with RAC inhibitor reduce the growth of tumor generated only with breast cancer cell. Wherever the treatment of this gas with the inhibitor in the presence of the breast cancer cell increase the growth of this tumor. When this tumor generated with co-culture of breast cancer cell and CAF were treated with RAC inhibitor, they grew significantly less. And importantly, the blockage of the interleukin-1 beta signaling abrogate the effect of RAC1 inhibition, and we get working not only at decreasing the proliferation, tumor proliferation, but as well in we get less metastatic tumor. As conclusion, we have found that inhibiting RAC1 activity in CAFs promote tumor proliferation and tumor invasion in vitro and metastasis in vivo through the secretion of interleukin beta. And we propose that an effective new treatment will be to inhibit at the same time this tumor with RAC inhibitor and in combination with interleukin-1 beta inhibitors such as Anakira that are at this moment in the preclinical trial. Just acknowledgement to my group, Laboratory 4, and as well collaborator and the funding of this project. And thank you very much for your attention.
So thank you so much for the presentation. I think, I mean, this provides a lot of insights in the crosstalk between stroma cells and breast cancer. So I will start with one question. So do you think this is a general mechanism for breast cancer or might depend on the subtypes of the breast cancer?
Well, I think this is more depending on the breast type of breast cancer. So, well, in general, if you treat tumor cell, only tumor cell with RAC inhibitor, one thing that you find is that you abrogate proliferation and metastasis because this is a very important regulator of tumor dissemination. The problem is that when you combine the tumor cell with the microenvironment, or in this case, where we have analyzed the cancer-associated fibroblasts, we have found an opposite effect. So at the end is that it has been always proposed that inhibition of RAC1 could be a very nice target, but we have shown is that depending on the interleukin beta signaling in the breast tumors. I mean, what I want to say is that if you block RAC1 in the cancer-associated fibroblast, what you get is an increase in interleukin beta secretion. So if the breast tumor cell express interleukin beta receptor, you are going to get a very nice response, therapeutic response. So in the case of triple-negative breast tumor, it's known that most of this tumor express interleukin beta receptor. So that means that have enough interleukin beta receptor. So it could be a very good strategy to treat only with RAC1 inhibitor, only in this breast tumor that do not have interleukin beta signaling pathway active. In that case, if you combine both interleukin beta inhibitor together with RAC1, you get a much better therapeutic response. But if you do not have interleukin beta signaling pathway after, you can just treat with RAC, you will get exactly the same effect. So it's dependent on the tumor. But in this context, if you want to use RAC1 inhibition, you need to check how is the interleukin beta signaling pathway in the breast tumors. And in the case of triple negative, is the one that express more of this receptor. So it would be better for luminal ones, for instance.
Okay, exactly. So yes, and I think, as you said, it is very important to characterize the tumors itself in order to decide, exactly the best therapeutic application. Yeah. And I have another question. I mean, it's more general. I mean, since you know, CAF can also in some way shape the tumor the immunological cells that might infiltrate the tumors. So you believe, or you can foresee that the mechanism you see can also apply to the crosstalk with, for example, macrophages, dendritic cells.
Yeah, sure, because interleukin-1 beta is a you know, cytokine that has a very important role on that. So yeah, so inflammation. So sure. So one thing that we would like to analyze is to generate 3D system to not only check the culture of tumor cell with CAF, so in combination as well with the immune system that I think in this context is playing a very important role due to the cytokine that is expressed, or SDF1, there is the stromal derived growth factor that is secreted and play a very important role, for instance, in angiogenesis. So we think that decreasing SDF1 does affect as well, not only immune cells, but as well to angiogenesis that, as you know, plays a very important role as well in metastasis. That is there, for sure.
Okay, I don't see the other questions, so I'd like to thank you.